Okay, we're going to go ahead and start. We're going to take a look first at joints and articulations. And if we have time, I'd like to go into at least do part of the skeletal muscles and see how that goes with us. And that'll get us a leg up, no pun intended there, on where we are after fall break. I mean, spring break, sorry, fall break. Yeah, it's Monday, so I can tell you that. Anybody have any questions on anything? Okay, now I'm going to go ahead and go into joints and articulations, and we will see where we go with this. So, okay, joints and articulations deals with movement and structure of the joints. Now, a joint is where two or more bones come together and move against each other. That's what articulation means. It's a movement of bones. So what we're looking at, when we look at a joint, we can classify it as either by movement. There's three different types of movement, or what kind of structure it has. And so we talk about these classifications. Articulations, the movement of bone against bone. Two bones come together, two or more bones come together to form a joint. Now, there are three types of joints based on movement. The immovable joint that doesn't move at all, the slightly movable, which is obvious, and the freely movable. And so we have these three classifications here based on the type of movement we encounter. The terms here for joint movement, first of all, we have what's known as synarthrotic joints. Probably detect the, part of the word of, arthrotic, like arthroscopic surgery or arthritis in here pertaining to bone. Well, synarthrotic movement, little or no movement of a particular joint. And so we think of the sutures in our skull as synarthrotic joints. They don't move. We don't want them to move. We think about the symphysis, the mental symphysis between where the two edges of the mandible grew together when we were in utero. That's a joint that doesn't move. We don't see our teeth in our sockets moving around very much. We don't want that to happen either. And the first of the costosternal joints, now that is where the first rib articulates against the sternum. That joint doesn't move very well easily either. So these are the synarthrotic joints. The amphiarthrotic joints are the slightly movables. So if the synarthrotic is the immovable, amphiarthrotic is slightly movable, the disc between our vertebrae, the rest of the joints in the sternum with the ribs and the pubic symphysis, they have a little give to them. Our ribs have to give so we can raise and expand and contract our chest so we can breathe. The intervertebral disc has to have some give to it as we move and as shock goes up our backbone. And the pubic symphysis has to also function as a shock absorber and have a little give to it as we move and walk and run and climb stairs and ride bicycles and do things like that. The freely movable joints are everything else. They are the diarthrotic joints. The shoulder, the knee, the hip, the elbow, the fingers, and toes, the interphalangeals, the tarsal bones and the carpal bones. These are all freely movable joints, and we move around all the time. Most of the joints in our bodies are diarthrotic. So this is the movement. Synarthrotic, immovable. Think of the sutures in the skull. Amphiarthrotic, slightly movable. Think of the ribs, the sternum, the rib bones articulating against the sternum. And diarthrotic is everything else, the freely movable stuff. So, okay. Examples of our joints by classifying them by movement: the synarthrotics, the immovables. The bones are held together very tightly. They don't move. They have a layer of connective tissue. There, like in the suture lines in our skull, there are some very thin layers of connective tissue here. They're not going to move. Our teeth are held in our mandible and our maxilla by connective tissue. There are ligaments that hold them in place. Very powerful ligaments. That the and the socket the tooth is in has a very, very, very thin layer of connective tissue between the bone and the tooth itself. So these are not joints that are going to move. The teeth in our socket don't move. The suture lines in our skull definitely do not move. We don't want them to move. We want them to be immobile. At one time, they were movable when we were infants and children, but we don't want them to move now. Slightly movable joints, the amphiarthrotic joints, separating the bones are cartilage of some sort, either hyaline cartilage or fibrocartilage. The ribs attached to the sternum are held in place by hyaline cartilage. Except for costosternal joint number 1, the ribs are held in place by hyaline cartilage. The pubic symphysis and the intervertebral discs are fibrocartilage. They separate the bones so that we don't have any friction, but also give us a little flexibility. Now, the type of structure we were talking about was a symphysis, like the pubic symphysis between the pubic bones in the pelvic girdle. The other type of joint here, of a slightly movable joint, is called a syndesmosis. And we see this in place at the area we refer to as the ankle. It is a connection between the fibula and the tibia at the lateral malleolus. Now, the lateral malleolus of the fibula is held tight up against the tibia on the lateral side, on the outside. Because remember, the tibia and the fibula surround the talus bone that sort of sticks up here. Well, we also attach the lateral malleolus to the tibia here, a very strong, slightly movable structure. We have a ligament holding that bone together, holding that joint together, but we can sprain that joint. We can injure that joint. That is the where we're going to see most injuries occur with what we call an ankle sprain, where we are tearing the ligaments that are attaching the tibia and the fibula together. For example, let me show you here. You can see here's the talus right there. Here is the fibula there. This is the lateral malleolus. And here is the tibia. Here, the medial malleolus is around there on that side. Medial malleolus. And so we have these ligaments here and here that are holding, it's holding the end of the fibula, the lateral malleolus, to the talus and to the calcaneus here. And this, remember, the fibula is a weak bone. It can't take a lot of stress. And so it is very common for injuries to occur on the outside of the ankle, on the lateral side of the ankle, where the tibia and where the fibula is attached to the talus, where it's attached to the tibia, where it's attached to the calcaneus. You can see the injuries occur here. When we flex the wrong way, we can tear either one of these ligaments. We can tear the ligament that attaches it to the, let me get back one here. We can tear the ligament that attaches it to the tibia. This is the weak side of our ankle, the outside. Okay. We call this a sprained ankle. You know, we can sprain either side, but the side that is the weakest is on the outside, the lateral, a lateral sprain. Okay. The slightly movable, the other type of joint is the symphysis. Here we see fibrocartilage instead of a ligament. We have fibrocartilage holding, you know, as the area between the vertebrae and between the pelvic bones here at the pectoral girdle. I mean, at the pelvic girdle, we have, you know, where the green arrow is here, you know, fibrocartilage is a soft tissue. It doesn't show up in X-ray, but that's where the pad is. Just like the intervertebral discs in the vertebrae. Shock absorbers, slight mobility at these joints, a little bit of give, but not a lot of give, a little flexibility, but not a lot of flexibility. But here we have the fibrocartilage as opposed to the syndesmoses, which had the ligaments. Okay, and there's our intervertebral disc right there. Pads of fibrocartilage, same material we have at the pubic symphysis. Now the freely movable joints, the diarthrotic joints, are everything else. The fingers and toes, hands and feet, knees and elbows, shoulders. The bone ends are covered with hyaline cartilage, so they don't rub against each other. There's a space in between the bone ends called the joint cavity, and the joint cavity is covered by a capsule made out of dense connective tissue and filled with a fluid. We have what's called synovial fluid in here. It's sort of like a gel that lubricates the space between these two articulating bones at a freely movable joint. And we also call them a synovial joint. So we have a joint capsule. We have filled with this gel called synovial fluid, and that gives us free range of motion in here. So those are the freely movable joints. Most of the joints in our body are going to be freely movable. So we have, this is the freely movable or diarthrotic joint. Di, I guess, because there's two bones involved here, and they have complete range of motion. Now let's go here. If we're looking at these joints by structure, so we looked at them by movement. Immovable, slightly movable, freely movable. Let's look at them by structure. They can be fibrous joints, they can be cartilaginous joints, they can be synovial joints. Most of the joints in our body are synovial joints, I'll tell you that. So fibrous joints, no cavity. Only synovial joints have a cavity. The bones are held together by connective tissue. There is little or no movement. The sutures of the skull are a classic example of a fibrous joint with no movement. Another type of fibrous joint, though, again, is what we looked at earlier on the ligaments at the end of the tibia and the fibula. The bones are held together by collagen fibers. Again, no joint cavity. All of these fibrous joints have little or no movement. The sutures in the skull, the teeth in the alveolar, in the gomphoses, the end of the tibia and fibula, and the end of the ulna and the radius. The end of the ulna and the radius, where they come to, where they are articulating at the bones of the wrist, the carpal bones of the wrist. And so we have, we're going to use our connective tissue here. Cartilaginous joints again. Now, this is something we talked about connective tissue. Now, here we have another type of cartilaginous joint I haven't mentioned before. We've already talked about hyaline cartilage holding ribs together to the sternum. We've talked about the fibrocartilage pads between the vertebrae and between the pubic symphysis, or at the pubic symphysis. That's a cartilaginous joint. You know, so we've got fibrous joints, like the sutures and suture lines in the skull, and the ends of the tibia and fibula, and the ulna and the radius. Now we'll go to the cartilaginous joints. Hyaline cartilage holds ribs holds the ribs to the sternum. That's a cartilaginous joint. The pubic symphysis is a cartilaginous joint. The intervertebral discs are a cartilaginous joint. We've got one place that we have not seen yet for cartilage, and that is at what we call the epiphyseal plates of the long bones. These are the growth plates of the long bones. And so we have, I've mentioned the costosternal joints where the ribs and the sternum come together. I've mentioned the pubic symphysis. I've mentioned the intervertebral disc, but now we have the epiphyseal plates. So I mentioned this already there's another example of a synchondrices here, hyaline cartilage between bones. We have it at the first costosternal joint. We also have it between the growth areas in our long bones. This is what's known as a synchondrices. So what is this epiphyseal plate? Well, the epiphyseal plate is our growth area. Our long bones, like the femur and the tibia and the humerus and the ulna and the radius, have growth plates at each end. And as we go from childhood into adolescence, our long bones grow at each end of the bone. There's a growth area at each end, and the bone grows lengthwise. The growth plate is made of hyaline cartilage that is gradually converted to bone. Now, if we look at the X-ray here on the left, we call this the epiphyseal plate. If we look at the X-ray, we see a dark line. We see a dark line at the end of the femur, and we see a dark line at the beginning of the tibia and the fibula. That dark line doesn't mean there's a separation there. It means that's where hyaline cartilage is located. That means those bones are still growing in opposite directions. So we're getting longer. They grow from these regions. We call this the epiphyseal plate or the growth plate. This is a cartilaginous structure in here. Now, once we get past age 23 or 24, somewhere in that neighborhood, those growth plates are going to shut down. And all we see then is a white line. We see a scar in here. This is the epiphyseal line or epiphyseal scar right across here, for example. There it is. There it is, there. That white line. No, the bones are no longer growing. The cartilaginous joint has closed. So there is no more growth there. The individual has reached their adult stature, and it usually doesn't take place till you're like 23, 24, 25 years of age. So our skeleton isn't finished forming for about 25 years after birth. So it really is a long period of time when the skeleton is growing. So, but under that age, childhood, adolescence, late adolescence, we can still see a line. You can see a line here, and even over here on the fibula, where we're having growth. And at the other end of the femur, you're going to see another growth line up here at the top of it, and another growth line at the other ends of the tibia and fibula. So, because the bones are going to be growing outward lengthwise as we go along here. So this is a good example of what we would call, again, this is a cartilaginous joint, or what we call a synchondrices. Cartilaginous joints, good. Okay, now, comment here about being double jointed. I got to talk about this. There's no such thing as being double jointed. We all say it. We all know somebody who is extra flexible and can, do strange things with her fingers and toes and hands and feet and arms and legs and have extreme flexibility. What happens is that they don't have extra joints. The person who is double jointed doesn't have extra joints. What they have is extremely stretchy ligaments around the joints. The capsules, the coverings of the diarthrotic synovial joints are extra stretchy and flexible. And so instead of being limited by the capsules at the synovial joints, they have more give and play. They're extra flexibility at this point. And so they can, hold their finger out straight and bend down the tip of their finger, which many of us can't do. Or they can, lock their ankles behind their neck, and not have any discomfort. Most people have a hard time doing something like that, if at all. So, but there is no such thing as being double jointed. Now, is it worth getting in an argument over? No. But now you know that they're just extra stretchy and extra flexible. Something else to consider. You may have heard at some point someone tell you, don't crack your knuckles, it will cause arthritis. Not true. Arthritis is caused by wear and tear on our bones over time. And 95% of us will develop arthritis as the price of living, simply by wear and tear in our bones. Cracking your knuckles only relieves air pressure in the synovial capsule. It releases pressure in the joint, and it feels good, but it has absolutely nothing to do with developing arthritis. So that one, that's a common legend, common urban legend. Maybe it's an old wives' tale. I don't know, wherever you want to call it, but cracking knuckles does not cause arthritis. We're all going to get arthritis anyway on our own. Cracking our knuckles isn't going to make it any better or any worse. So anyway, so here are these synovial joints. The joint, two bones come together, like these are phalanges that you see in the illustration here. There is a cavity filled with synovial fluid. Synovial fluid is a very thick gel in here. It's like a very heavyweight motor oil or a very thick syrup in here. And that allows the flexibility of the joint without any friction at all. And so we have each end of our bone covered with hyaline cartilage to prevent them rubbing together. Then we have this capsule forms around these two bones here. And then within the capsule, we have the fluid, and we keep generating synovial fluid. So we have free range of motion without any irritation or any kind of pain. Our shoulder, our hip, our elbow, our knee, the carpal bones, the interphalangeals, meaning all the fingers and toes, are going to be synovial joints. It gives us this incredible range of motion. Think about what we can do with our arms and legs, hands and feet, fingers and toes. So synovial joints are the most common type of joint in the body. They are the freely movable diarthrotic joint. We have more of these than anything else. For example, Here is a synovial joint at our shoulder, showing some of the range of flexibility that we can do, that we can move here. And if you look at the illustration on the right with the muscles in place, you can see just which muscles are involved with this kind of motion. And you can't even see the joint itself because it's covered with a very thick capsule to begin with. So, but this is a freely movable synovial joint at the shoulder. Not only can we raise our arm like this, but we can also rotate it in almost a full 360 degrees around the shoulder. Now, structures in our synovial joints to make them work better, we have lots of pads of cartilage. We have various pads of cartilage at our knee called the meniscus. The meniscus sets on top of the meniscus sets on top of the tibia, and the condyles of the femur rest on these pads. They stabilize the joint. The ligaments and tendons hold the joint together, and the bones rest on top of these pads of cartilage. There's no friction, but it also is a joint stabilizer. We have them in our knee. We have them in our jaw. We have them with the sternum and the clavicle, where the clavicle and when our collarbone articulates with the manubrium, we have a pad of we have a meniscus there. We also have sacs of synovial fluid called bursa. We have these found in our muscles and our joints, where tendons and ligaments would normally rub together. If bones and muscles and tendons and ligaments are going to rub together, we're going to prevent that by having these sacs of lubricant sort of suspended in between there, so that they rub against the lubricant, the bursa sac, and there is no friction, because if there's friction, they'll have pain. And if we have pain, we're not going to do something. We're not going to move a structure if it hurts. And so here we see this is a bursa sac right here between two bones. This is the structure between the acromial process and the coracoid process on the clavicle, and we have a sac of bursa in between, so there's no friction moving there. Here we see what the bursa sac looks like in front of the patella. This is an MRI. Here is there's the femur. Here's the tibia. There is the kneecap, the patella right there. And here is the patellar tendon right here. And here is the bursa sac. The bursa sac is, show you. Here's the bursa sac here and here. And so there's the patellar tendon there, there's the kneecap there. And this sac here is filled with synovial fluid designed to function as a friction fighter. If we abuse that structure, it becomes inflamed and it hurts. Our knee will hurt. A constant pressure, constant motion of the same type, repetitive motion injuries are going to cause the bursa sacs to become inflamed. Carpal tunnel syndrome, you may have heard of that, caused, if you use the muscles in your forearm repeatedly doing the same type of action, whether you're using the computer a lot or having some sort of repetitive motion, you inflame those, you inflame the bursa sac. In this case, the bursa sac is a long column, a tube that surrounds the tendons and ligaments of the forearm to reduce friction. But if you have repetitive motion, doing the same thing over and over and over and over again, You inflame that sac and it becomes very painful. The same thing applies here. Constant pressure on the knee at that particular point, or constant torsion, excuse me, of the knee. And the inflammation is called bursitis. And you can see how it shows up here, because then you're looking at your tibia, right in this area between the tibia. There's the femur. Right in between is the meniscus. Same over here, but here is our bursa sac inflamed. Some sort of repetitive action is going to hurt there. Okay. Now, the most complex joint in our bodies is the knee. The knee is a hinge joint because it bends backwards. It has the ability to have a slight rotation and a slight gliding action. The knee is very quick to point out when we've gone too far on any of that. We have three joints that come together. It is the joint between the patella and the femur, and the medial and lateral tibia and fibula. The tibia and the femur come together on two areas. So we have a lateral connection between the tibia and the femur, a medial connection between the tibia and the femur, and then of course the femur and the patella itself. So we have three joints that work together there. It is not a complete capsule joint. It is not enclosed on the anterior surface, because you can feel your kneecap. If the entire joint was enclosed, you could never feel your kneecap, but you can feel your kneecap moving around if you play with it. It's surrounded on the medial, lateral, and posterior sides, but the anterior part of it is not part of the capsule. It is, arguably the most complex joint that we have. It's designed for us to maneuver in multiple directions. It's designed for us to start and stop. It's not designed to bend backwards. It's designed to have a hinge joint that bends forward. And if we try to bend it backwards, it hurts. That part doesn't work. There's our knee. There's the movement of our knee. You can see here in the x-ray, you can see that the patella slides up over top of the femur as our leg bends, and the patella is held in place by a ligament that connects to the tibia and to the femur, and it helps to stabilize our joint. But that's the direction that the knee will bend. Again, it's a hinge joint. It can slide a little bit side to side. It can slide a little bit forward, but that's all. Its range of motion is primarily to hinge so it can bend backwards, or, like we're seeing here. Now, if we look at a model of the knee, you can see a number of structures here that make it so complicated, but it works pretty well for us. This first thing we see is a structure that we've all probably heard of at some point or another. This is known as the anterior cruciate ligament, the ACL. If you follow any kind of sports or pay attention to any sports, or if you've played sports, then you've probably all heard the term about an ACL injury. It happens in contact sports all the time. Now, the anterior cruciate ligament, first of all, if you have an anterior, you got to have a posterior. The anterior cruciate ligament is a connection between the tibia and the femur. And it's called a cruciate ligament because there's a posterior cruciate that allows that they cross over each other, and cruciate means across. So here's the anterior cruciate ligament. There's the patella. The patella is pushed over to the side here, so you can see so the ACL is exposed. Because normally the patella would be right in the front here. There's the patellar ligament that holds the patella. back here. This is this is a meniscus here and here. In fact, this is the medial meniscus, and this is the lateral meniscus. How do I know that? Well, there's the fibula right there, and the fibula is always lateral. So we have the lateral meniscus here and the medial meniscus right here. And this is, of course, the femur here and the tibia right there. Now, the anterior cruciate ligament, we often hear about people who play sports, athletes, tearing that ACL. They have an ACL tear. It seems to be the most common type of injury, but there's also a posterior cruciate ligament which can itself be torn too. So let's take a look here at this illustration here. There is the end of the femur. There is the lateral condyle, the medial condyle. There's the lateral condyle, the medial condyle. There is lateral meniscus. There's the medial meniscus. I just showed you that on my little sketch. Now the ACL connects to the anterior intercondylar area of the tibia. In other words, right here, the area in between the condyles and the tibia in the front. It's the area in the front of the tibia. There we go. Here's our tibia. Oh, stop that. Nope, too far, sorry. Okay. Now, here's our tibia right here. This is a condyle here and a condyle here. The intercondylar region is the area right in here in between the two condyles of the tibia. Here's the ACL coming down here. It attaches to the anterior condylar region here in the front of the tibia, and it extends to the lateral condyle of the femur. So it goes up into this area up in here. This is the ACL right there. Keeps us from sliding the tibia forward and hyperextending the knee. The PCL connects in the back on the posterior intercondylar area and to the lateral side of the medial condyle. So they cross over like this. Let me see if we have a better picture. This next slide's a better picture. Let's go on to the next one. And okay. So this area right here where the ACL is connecting to the tibia is the intercondylar region. Right here, this is the intercondylar region. Why do we call it that? Because it's between the two condyles. This is a condyle and that's a condyle on the tibia. The tibial, the anterior, meaning in front, anterior means in front, and the tibial anterior intercondylar region, right here in the front of the tibia, between the two condyles. That's where it connects in the front. Now in the back, it's going to connect on the medial surface of the lateral condyle. So what does that mean? Well, if you were to look at the, let me, okay. Here is, if we're looking at the, this is a posterior view of the knee. This is the lateral condyle of the femur. This is the medial condyle of femur. Here comes the ACL right here. The ACL attaches to the medial side. This is the lateral condyle, but this is the medial side of the lateral condyle. This is the lateral side. I know it's confusing. So it comes across, so it comes up, there's our ACL right there. It comes up from the front and goes to the medial surface on the lateral condyle. The PCL comes up from the back and goes to the lateral surface of the medial condyle. They cross over. I know it's very confusing when you think about this, but they cross over. That's why they're called cruciate, because they cross. Now, and you can see now here's where we tear. The ACL is frequently torn in that area where the two the ligaments cross over. As you can see, the area that's highlighted in red, you know, that's attaching itself to the medial side of the lateral condyle, and that seems to be where the greatest stress is on the ACL. PCL can tear too, you know, in its similar location on it. Because remember now, the PCL is attached at the posterior intercondylar region here and attaches to the lateral surface of the medial condyle. Okay. Here we're taking a look at now this is a same illustration we saw on the animation, but now we're looking at the model. And here we can see the structures. There's our femur right there. There is the PCL because it's attached here at the posterior intercondylar area, and it attaches to the lateral side of the medial epicondyle. So posterior cruciate ligament. This is the medial condyle. This is the, mess it up with the drawing. This is the medial, and this is lateral. This area over here is the lateral surface. This is the medial surface here. So if you have a medial condyle and a lateral condyle, each one's going to have a medial and lateral surface. Here's the medial surface here on the lateral condyle. There's the lateral surface on the medial condyle. The PCL comes up from the intercondylar region here in the posterior, comes up here and attaches on this side. The ACL attaches on the medial surface of the lateral condyle and extends forward and attaches in the front. Now let's see if I can clear this and show you now. PCL there, the lateral collateral ligament for the fibula, or lateral, I like to say lateral collateral. I don't want to give the fibula any more credit than it's due. It attaches the fibula to the femur. It's on the lateral side of the leg. That's about the only connection that the fibula gets. There is our lateral meniscus. There's our fibula. Remember, this is the lateral condyle. There's our tibia right there. Medial meniscus, and lateral meniscus. And there is the medial collateral ligament. You have a lateral, you got to have a medial because you got one on each side. Here we see the lateral collateral ligament. There's our femur, there's our fibula, there's our tibia, there's the patellar ligament, there's the tibia, there's the fibula, there is the lateral collateral ligament right there. There's the femur. And of course, this is the lateral meniscus right here. Problems with our knee. We dislocate our knee easily. You know, our knee is forced to move in directions that we didn't want it to move. We don't like that at all. It makes us very unhappy. Makes our knee very unhappy. It can be pushed back in shape. We may need surgery to fix it because we may have torn apart the ACL or the PCL or one of the other ligaments, the medial or collateral ligaments. Medial collateral or lateral collateral ligaments may be damaged. Any number of things can happen here. So the knee is dislocated, or maybe your patient gets very lucky and all they have to do is push it back in place. So sometimes a dislocation only just means manipulating the bones back into position. And sometimes that's all it takes. So, knees wear out over time. Many older people have knee surgery to replace the damaged knees. And so what will happen in knee surgery is that the worn out areas are going to get removed, surgically removed. They're not going to take out all of the knee. You're going to take off the worn areas of the femur and the tibia, and you're going to replace that with an artificial knee in here. And what you're doing is essentially putting on new tibial condyles, like right there, that's the tibial condyle. There are the condyles for the femur. There is the artificial meniscus. We attach the existing patella back into its position with the ligament, because wear and tear erodes the condyles, both on the tibia and on the and on the femur. And so instead of trying to repair the damage, we just replace the damage with usually some sort of titanium structure. You know, like there's the condyle for the tibial condyles, there's the femoral condyles, there's the meniscus pad that goes in place there, and then we repair the damaged, we cut off the damaged area on the patella, and our knee is as good as, is better than it was before. Many older people have knee surgery and get the quality of life back that they had before, or better. So knee replacement looks like this. The lateral and medial ligaments, the lateral collateral ligament attaching the femur to the fibula, and the medial collateral ligament attaching the femur to the tibia are left in place. And you see them here in the action. But now our motion is we have the artificial knee rubbing up against the plastic spacer, the artificial meniscus. And there's the artificial condyle here, leaving our patella attached to it, the patellar tendons. And now we have no pain. We have freedom of movement, and we have no pain at this structure. We have wear and tear at the hip. We do hip replacements all the time. The head of the femur and the neck of the femur wear out over time. The acetabulum wears out over time through constant motion and wear and tear. And what we'll do is we will simply cut off the head and neck of the femur and put an artificial hip in place in the shaft of the femur and put a new acetabulum in place in the socket, because it would do no good to put a stainless steel or titanium head in there and just wear away the old bone. So we put a new socket in there too. And it is a very quick surgery for this. You notice here we see in the x-ray, you can see that it only took off part of the femur. Sometimes the cut of the bone is taken down much further down the shaft, and the shaft of the artificial hip extends even further. So sometimes this shaft can go way down in the bone, and we've cut off the bone, you know, below the trochanters, for example. And then of course there's the new acetabulum, and we usually have, again, we have a liner here to wear against. So, and full range of motion again. Look how far down the shaft this often goes to show that. So, but it works. It works very well, and many people have it done every day. So, okay, that is everything on joints and articulations. Now I'd like to start, let me get out of here. And I want to go into muscles, and we'll, let's at least start muscles and see how far we get. I won't keep us till 3:45, I can tell you that. So just trust me. So, okay, let's get into muscles. Okay. Here we go. Now, a couple comments on muscles. There's only 60 muscles on the list that you have to know. And muscles are not going to be on the bone test. The bone test is through the skull, the axial skeleton, the appendicular skeleton, and the joints and articulations. Muscles are going to be test number 3. But I thought since we could introduce it now, and that'll buy us some time later on after spring break. So, okay. The list of the muscles, and 2 terms here, 3 terms, origins, insertions, and actions. If you go into your study guide, or if you look in eLearn, I think I have, in addition to the PowerPoint, I have the bone list in there too. So, and if not there, you can find it in the study guide. If you look in the table of contents for AP1 Lab, on that, you'll find that the second or third listing in the table of contents is the lab study guide. If you go into the lab study guide, which is I think it's a PDF file, you'll find a list of all the muscles. Well, there's only 60 muscles, but we also focus on the origin of the muscle, the insertion of the muscle, and the action of the muscle. Now, I'm not going to address all 60 muscles. In fact, you're going to see exactly which ones I want to focus on: origin, insertion, or action as we go along here. So, muscles have 2 points of attachment, at least 2. The origin is where a muscle attaches to a bone that doesn't move. The origin of the muscle is where it is attached to a bone that doesn't move. It's anchored on that bone. The insertion is where the muscle attaches to a bone that moves. The insertion is where the muscle is pulling on the other bone. It's a movable bone. We attach to the movable bone. For example, if you remember the radial tuberosity last week when we looked at the radius, the radial tuberosity is the insertion of the biceps muscle. The biceps muscle, the muscle that we feel in our upper arm, on the anterior surface of the upper arm, the large muscle on the anterior surface, its origin is on the humerus. Its insertion is on the radial tuberosity, that little bump that sticks up on the radius. That is the movable bone. So origin is the bone that doesn't move. insertion is the bone that moves. And so we always have at least two connections, an origin and an insertion. Sometimes they have two origins. Sometimes they have more. The movement is caused by the muscle pulling on the movable bone. See, muscles have to use bones to get their work done. Muscles aren't strong enough to allow movement to occur on their own, but they can amplify their strength by pulling on bones. Bones function as levers to amplify the strength of the muscle. So we get things done, we can do things, we can move. We pull on the movable bone and the muscle amplifies its strength. So, and of course, the bone that doesn't move is the origin. And what it does is the insertion. So a muscle, the insertion of the muscle is where it attaches to the movable bone. The insertion of the biceps is going to be the radial tuberosity. Its origin is going to be the humerus. Now here's an example of an origin and insertion. This is a very large muscle on each side of our neck. And its origin is on the sternum and the clavicle. And its insertion is on the mastoid process. And this muscle allows us to turn our head to the left or to the right or to nod up and down. So here we see the insertion is at the mastoid process right there. The origin is at the, oops, let me back up. Sorry, I got carried away with myself. There's the origin. You can see there's two different places where it originates. It originates attached to the sternum and also on the clavicle. Now, let's take a look at the muscles of the arm. The first muscle we see here is one that we're all familiar with. This is the deltoid muscle. This is the one we get injections in right there. Covers our shoulder. This is the deltoid muscle. Here we have the biceps brachii, the large muscle on the surface, the anterior surface of our arm. Here we have the triceps brachii on the inferior surface, the large muscle underneath. Here we have what's known as the teres major. We find it located here underneath, it's sort of underneath the shoulder. Here we have what's known as the brachioradialis. The brachioradialis is the muscle. Last week when I showed you how we turn our radius, like opening a doorknob, turning a doorknob, or turning a screwdriver, or unlocking something, turning our radius, moving it over the ulna. It is the brachioradialis that allows us to rotate our arm in that circular pattern. And in between the biceps and triceps is a muscle called the brachialis, right in here. So the biceps is on top, the triceps is underneath, the brachialis is in the middle, and the brachioradialis extends from the humerus down to the end of the radius. So now, the deltoid muscle covers the shoulder. It originates on the scapula, and it inserts on the deltoid tuberosity of the humerus. It originates on the scapula and it inserts on the deltoid tuberosity. It allows us to move our arm move our arm out, move it out to the side. We can flex our arm out to the side. That's the deltoid. It's really just what's really important is that it inserts on the deltoid tuberosity. Okay, now the brachioradialis, that's the second muscle we looked at. The deltoid covers the shoulder. Here's the brachioradialis. Its origin is on the humerus. It inserts on the radius down here at the distal end of the radius. It allows us to rotate our arm, like when we're turning a key, turning a screwdriver, opening a doorknob. It's the brachioradialis. Now here we have a term, antagonistic muscles. The biceps and the triceps work against each other. They have opposite actions. The biceps is on the superior surface. The triceps is on the inferior surface. There's the biceps brachii. Underneath it, over here, is the triceps brachii. They're antagonistic. They work against each other. By the way, the biceps has two heads. That's what biceps means. Bi means two. The biceps has two heads. The triceps has three heads. Okay, a little factoid there. Now, biceps brachii and triceps brachii, they are antagonistic muscles. And the biceps brachii originates on the scapula. So you got to remember, the biceps brachii, the biceps originates on the scapula. It inserts on the radial tuberosity, and it causes us to flex our arm at the elbow. So if your arm is straight out with the palm of your hand down, the palm of your hand's up and your arm is held straight out from your body, and you bring your fingertips back and touch your shoulder with it, you just flexed your arm. So when you're pulling the arm towards the shoulder, that's flexing the arm, you are pulling on the radial tuberosity of the radius, causing the forearm to come back towards the shoulder. That is flexing. And the opposite action is from the triceps. The triceps extends the arm. The triceps is on the underside, on the inferior surface here of the arm. It has the opposite action of the biceps. The triceps inserts itself on the olecranon process, the elbow. Its origin is also on the humerus and the scapula. But what this one does is it extends the arm. So if you're sitting there with your fingertips on your shoulder and you want to get your arm straightened out again, your triceps will pull on the olecranon on your elbow and pull your arm straight out. It will extend the arm. So flexing with the biceps, pulling the arm back towards you, extending, pulling it away from you. The triceps brachii. Note the animation there. Note how this is the triceps brachii right here. It inserts here on the olecranon process right there. And when we pull on this, when this muscle pulls on the olecranon process, the arm is pulled back. It extends outward, as opposed to the action of the biceps, which pulls it. It decreases the angle. Let me show you. Back to the, so notice how when we pull on the elbow, it straightens the arm out. We're extending the arm, extending the elbow joint. The triceps inserts on the olecranon process, the elbow. The biceps inserts on the radial tuberosity. Now, here's a set of muscles that gives lots of people problems, both at a young age and at an older, more of an, older adults, elderly individuals. The rotator cuff. They are a collection of four muscles that form a cup around the glenoid cavity to hold the humerus in the socket. And the rotator cuff muscles, there are four of them involved. And because of their range of motion, they allow the humerus to move in just about any direction we want. they form this cuff to hold the humerus against the glenoid cavity. And the four muscles are what's known as the supraspinatus, the subscapularis, the infraspinatus, you might recognize these names, and the teres minor. So rotator cuff muscles. There is the supraspinatus right there. It is in the supraspinous fossa. It's located in the supraspinous fossa, a big flat area above the spine. There is the infraspinatus in the infraspinous fossa, right there. There is the teres minor, right underneath the infraspinatus. This is 3 of the 4 rotator cuff muscles. And over here is the 4th one, the subscapularis, on the underside of the scapula in the subscapular fossa that we looked at last week. So supraspinatus, infraspinatus, teres minor, and subscapularis. Those are the only 4 muscles in the rotator cuff. The teres minor is one of them. The teres major, which is this muscle, oh, let me go back, is this muscle right here, is not part of the rotator cuff. It's right next to the teres minor, but it is not a rotator cuff muscle. Even though you have to have a major if you have a minor, that's not one of the rotator cuff. It's the teres minor. Now, and here we see again, there is the supraspinatus, there is the infraspinatus, there's the teres minor. Yeah, and this is the teres major here. This is 3 out of 4. On the posterior surface of the scapula is the subscapularis on the underside. The infraspinatus and the teres minor are on the anterior surface. The supraspinatus is up here. Looking at it from this view, there's the supraspinatus, the infraspinatus, the teres minor. Subscapularis is on the underside. Now, what do their actions look like? Well, here we see, on the left-hand side, we see the teres minor and the infraspinatus. Okay, here we have the teres minor down there, and the, oh, stop that. And the infraspinatus here, and over here is the subscapularis. Over here is the supraspinatus. Now, of course, this is the humerus here, and that's the glenoid cavity there. Okay, so what's happening here is that the infraspinatus and the teres minor can pull the humerus back, up behind us. The subscapularis can pull the humerus forward. The supraspinatus can pull the humerus upward, and they all can work together. They don't work individually. They all work together. So you can pull up and back, or forward and back and up, or forward and down. There's all different combinations here of these actions that can occur. And so you see on the right-hand side, there's the supraspinatus there pulling the humerus up. There's the subscapularis pulling it forward. There's the infraspinatus and the teres minor pulling it backwards. But they're all working together. And they're all holding that. They all originate on the scapula. They all insert on the head of the humerus, every one of them. This is the easiest one to remember. All originate on the scapula, all insert on the head of the humerus. And here we see how they work together. There's the supraspinatus and teres minor. Supraspinatus there, teres minor here. But they're not going to operate in a vacuum. This could be pulling here at the same time this is doing this. Because you get this, look how you get this high range of motion up, elevating the arm. Here we see the infraspinatus and subscapularis. You know, subscapularis is pulling at the same time this is. So you get this range of motion here by combining the effects of all four of these muscles. And it wears out. These muscles get injured. We end up having to have surgery on our rotator cuffs to repair the tendons that attach the muscles to the bones. Typically, a rotator cuff tear involves a tear or an inflamed tendon, because there's the tendon attaching. You know, remember, muscles don't attach to bones directly, they attach to tendons, and tendons attach to bones. The rotator cuff, the tendons get worn out, and so they have to be replaced, or they have to have an insert put in to attach, you know, that the muscle attaches to the insert attaches to the bone. So, because, you know, a lot of wear and tear over time, you know, a lot of sports injuries involve rotator cuffs because we're asking our elbows, I mean, our joints to do things that they're not quite supposed to be doing constantly. And also elderly people have a lot loss of range of motion. And there's also injuries that involve rotator cuffs. People fall down and injure their rotator cuff. They fall off of bicycles. They fall off of treadmills. They fall downstairs. They trip and fall. They do things. They overextend and they damage their rotator cuff. So, and it requires surgery to fix it. Now in our leg, leg's pretty straightforward here. Let's take a look at this. I will tell you that if you ever look at a leg model, important thing to remember, the big toe is always on the medial surface. The little toe is always on the lateral side. So, okay, let's take a look here. First thing we see is the tibialis anterior in the lower leg. Tibialis anterior. It's on the front of the tibia. It runs right next to the anterior crest of the tibia. We also have what's known as the extensor digitorum longus. This is immediately adjacent to the tibialis anterior. This long muscle down here. This extensor digitorum longus allows us to spread our toes when we step. Because when we walk, we're not aware of it, but our toes tend to splay out to give us better stability. That's what the extensor digitorum longus does for us. Here we have the peroneus longus. It also helps with the motion of our feet. And if you have a longus, you generally are going to have a brevis. I would say you'd have a shortus, but you have a brevis, meaning short. And here we have the peroneus brevis, also involved with spreading out our feet, spreading out our toes. Here we have the gastrocnemius muscle, large muscle. We call it our calf muscle. And the gastrocnemius connects to our Achilles tendon. That's what this structure is back here. And there's the Achilles tendon. Directly underneath the gastrocnemius is a large flat muscle called the soleus, right there. Now, if we look towards the superior surface of the leg, we see the gluteus maximus, the question that nobody ever gets wrong. Everybody can find the gluteus maximus on the leg. There's the gluteus maximus right there. This other one, this large white muscle, large muscle right along in here on the lateral surface of the leg is called the tensor fascia latae. There. Yeah. So tibialis anterior. It's on the anterior side of the tibia. It is located adjacent to the anterior crest. If you look, when this comes around again, I'll show you exactly where that is. Right here is the anterior crest, the sharp edge of the tibia. Let me clear that off and get it to go around one more time. I can get a better angle on it for you. Right here, this is the anterior crest is that area right in there, that sharp edge, you know, our shin, if you will. The tibialis anterior is just to the lateral side of that. That's the tibialis anterior. Now, what does that do for us? The tibialis anterior allows us to bring our toes up. Every time we take a step, we go heel down, toes down. Heel, toes up, heel up. And when we put our heel down, our toes come up. Then our toes go down and our heel comes up. And so dorsiflexion causes our toes to come up. This is what the tibialis anterior does. It causes our foot to come up. Causes our foot to come up like this. So when our toes come up, toes up. That's what the tibialis anterior does. The toes go up and the heel goes down. So that's what the tibialis anterior does for us. So now, it dorsiflexes the foot, raises the toes. Gluteus maximus, large muscle on the back side, you know, often referred to as our butt muscle, allows us to rotate our thigh. But you know, at this point, I'm just asking you to identify it. It's gluteus maximus. And if we have a maximus, we have to have a medius. And remember, I said the other day that we don't give injections in the gluteus maximus because the sciatic nerve comes down across here. The gluteus medius is in this area right over here. Gluteus medius. That's where the injection should go, not in the maximus. So we can avoid hitting the sciatic nerve for us. Now, okay, there's the gluteus maximus. Now, in the upper leg, we have a set of 4 muscles you may have heard of called the quadriceps, the quads. 3 of them have the same name. The vastus lateralis on the lateral side, the vastus medialis on the medial side, the vastus intermedius in the middle, sort of like the cuneiform bones, you know, with the same name, just lateral, medial, and intermediate. We have the vastus lateralis, the vastus intermedius, and the vastus medialis. And then to top it off, we have the one on top called the rectus femoris. But these are the quadriceps. These are the 4 quadricep muscles. That's why they're called the quadriceps. So there's 4 of them. Okay. And what do the quads do? Well, the quadricep muscles allow us to flex our thigh and extend our lower leg. Notice how when the quadriceps contract, we can flex. This is flexing right here. When we, you know, let me go back. Decreasing the angle is flexing. This is flexing right there. The angle has decreased. So we flex our thigh, or we can extend our lower leg. If we kick our leg out, we are extending our lower leg. This is the actions. This is the actions of all the quadriceps. They all do the same thing. Flex the thigh, extend the lower leg. And whether they are the vastus intermedius, vastus lateralis, vastus medialis, or the rectus femoris, They're all the quadriceps. They all do the same thing. The antagonist to the quadriceps are the hamstrings. There are only three of these. We have the biceps femoris, the semitendinosus, and the semimembranosus. They're on the back side of the leg, on the posterior surface of the leg, directly below the gluteus maximus. There's the gluteus maximus there. We have the biceps femoris on the lateral side, the semitendinosus and semimembranosus on the medial side. The semitendinosus is on top of the semimembranosus. Here they are in the model. There is the biceps femoris on the lateral side. There is the semitendinosus on top and the semimembranosus underneath. It's very hard to see underneath the semitendinosus, but it's there. And these are on the medial side. Semimembranosus. Okay. Now, what does the biceps femoris do for us? It's one of the hamstrings. It's on the medial, it's on the lateral side of the leg. And what it does is to extend the thigh and flex the lower leg. So here's what a hamstring does, flexing the leg. It pulls the leg back. It pulls the leg back. Notice how the hamstring, it flexes this way. Here is the quad extending the leg. Because if we flex the leg and bring it back like that, let me, okay. If we're going to flex the leg, we're going to flex it, let me get a different color in here. There we go. We're going to flex our leg. This is flexing it. You know, it shortens the angle. This is what the hamstring does. It pulls the leg back like this. This is what the quad does. This is the hamstring. This is the quad. Extending the leg drives it forward. This is extending it. So see how we draw it back to flex it. We narrow the angle. We straighten out the angle to extend it here. This is what the quads do, extending the leg. Now you might ask, what is the difference between that and what I showed you with what the quad was doing earlier? Well, let me go back and we'll take a look at that. Let me go back a couple here. There's the quad. Now, we are flexing our thigh and extending our lower leg. The difference between what the hamstring was doing, let me bring my little diagram in here. What the hamstring does is pulls the leg back this way. The hamstring pulls the leg back. Let me change the color on that. Red. The hamstring pulls the leg back like that. What the quad does is pull the leg up. So, and then we flex our thigh by pulling it up this way, whereas the hamstring pulls it back. So that's the difference. We flex the thigh a different direction. The quads pull the leg up this way. We're still bending the leg, but we're pulling it up this way, whereas the hamstring pulls it backwards. When we straighten our leg out, we extend the lower leg. Notice how, get all this off. Now, oh, there we go. Now watch. Yeah, we are flexing our thigh upwards and then we're extending it back down. We're flexing it upward and extending it back down. If we go out to the combination, oh, let me. So here we're bending it backwards instead of going instead of bringing the knee upward, we're pulling the leg backward. That's what the hamstring does. It flexes the leg backwards. The quad extends the leg, but the quad would take the knee up this way. So that's the difference. Similar actions, two different sets of muscles involved here. So, okay. Sartorius. Straps, it looks like a strap. It runs across the front of the leg, extending from the lateral side to the medial leg. It wraps around the front. It helps to stabilize our leg when we sit cross-legged on the floor, called the sartorius. There's the gracilis. The gracilis runs all the way along the medial surface of the upper thigh, from the groin area down to the knee. And we also have a muscle here called the adductor longus. If we have a longus, we may have a brevis, but instead of a brevis, we have a magnus. We have adductor magnus. So these are the four muscles of the inside of the medial side of the thigh: the gracilis, the sartorius, the adductor magnus, and the adductor longus. The adductor magnus runs underneath the gracilis and underneath the sartorius. The adductor longus runs underneath the sartorius. So the sartorius is it's a strap type muscle. It allows us to rotate our thigh. It allows us primarily to sit cross-legged on the floor. And there is no other muscle as distinctively shaped as this. Yeah, sartorius. Now, on the lower leg, we see the gastrocnemius. It has a lateral head and a medial head. It attaches each head, the lateral head attaches to the lateral condyle of the femur. The medial head has its origin on the medial condyle of the femur. It inserts on the calcaneus by way of the Achilles tendon. This is the calcaneus bone down here. What the gastrocnemius does, the calf muscle, allows us to raise our heel when we step. It causes us what we call plantar flexion. Our heel comes up when we take a step, and then we raise our toes. We have dorsiflexion. Our toes come up, our heel goes up, and then the heel goes down when the toes come up, and that's how we step. Heel up, and we move. Heel down when the toes go up, and we walk heel to toe. And so the origins are the medial condyle and the lateral condyle of the femur, and the insertion is the calcaneus. This is our Achilles tendon right there, and that's the gastrocnemius muscle. We see it again here. Medial head, lateral head. Underneath it is the soleus. There's the Achilles tendon right there. And then what the gastrocnemius does for us is allow us to have plantar flexion, where the toes go down. Notice when the toes go down, the heel comes up. Notice the calcaneus there. We're pulling on the Achilles tendon, and if we pull on the Achilles tendon, this is the Achilles tendon right here. If we pull, the heel comes up and the toes go down. This is plantar flexion. Let me, there's how heel down, toes up. I'm sorry, toes down, heel up. I got it backwards. Dorsiflexion is the opposite. Toes up, heel down. Here we have heel up, toes down. This is how we walk. Toes down, heel up. Toes down, heel up. So let me get rid of those marks. And again, dorsiflexion, the toes come up. We have the tibialis anterior pulling the toes up, and we have the Achilles tendon and the gastrocnemius pulling the calcaneus up. So the toes go up or the heel goes up. That's how we walk. Okay. So just a few more muscles to go here. We have the torso and the head. The number one muscle besides the cheek muscle, butt muscle, that we never get, that anybody ever gets wrong, is the frontalis muscle. It's a very thin muscle located right on the frontal bone. Unlike the frontal bone having one big bone, we have two muscles here, and we use the frontalis muscle to show expression. It's a very thin muscle. After all, you can feel your frontal bone through your skin. So the muscle underneath here has got to be very thin. Directly, two other muscles involved here with expression are the orbicularis oculi, it's a circular muscle, and the orbicularis oris. The oculi surrounds the eyeball, and the oris surrounds the mouth. And both of these are for showing expression. They don't have any other real purpose there. Now, let's take a closer look. There's the frontalis. Right on top of the frontal bone, very thin muscle. There's the orbicularis oris around the eyeball, and the orbicularis oculi around the eyeball, ocular, and orbicularis oris around the mouth. We also have the zygomaticus muscles right here. The zygomaticus muscles are also allowing us to show expression. Show you another view of those here. Here we have a close-up of the head with the frontalis here in the front. Over here we have the temporalis right here on top of the temporal bone. And again, it's a very, very, very thin muscle. There's the zygomaticus muscles there. Again, there's just two of them there. And all they are is to show expression. There's the masseter muscle. The masseter muscle inserts on the mandible. It's one of our two chewing muscles. It pulls the mandible up against the maxilla so that we chew our food. And again, here's our masseter muscle right here. But here is the big one. This is the one I showed you at the very beginning of this. This is the sternocleidomastoid. The sternocleidomastoid muscle has its origin on the sternum and the clavicle. Its insertion is on the mastoid process. This allows us to, when it contracts, it pulls our head to the left or right. If both sternocleidomastoid muscles contract, then our head bobs up and down. So sternocleidomastoid. And again, you can see how big it is. It inserts on the mastoid process. We know where that is, behind our ears, and its origin is on the sternum and clavicle on each side. And it allows us to turn our head to the left, it allows us to turn our head to the right, or it allows us to rotate, to bob our head up and down. So head rotation. Turn our head to the left, turn our head to the right, depending on which sternocleidomastoid muscle is contracting, the left one or the right one. If both contract, we nod our head like that. And sometimes we can get some pretty extra, or we can get head turning. Sometimes we get a little bit of a rotation that we didn't expect with the sternocleidomastoid. Very unlikely that you would ever encounter something like this. So now, the chewing muscles are the masseter and the temporalis. The masseter and the temporalis both insert on the mandible and pull the mandible up against the maxilla so we can chew, because we can grind our food between the teeth of the upper jaw and the lower jaw. There's the temporalis muscle. There's the masseter. And while the temporalis is also a very flat, thin muscle, it does have a real purpose. Now, there's the temporalis inserting on the mandible. Here's the masseter inserting on the mandible. Temporalis is a chewing muscle, attaches to the side of the skull and elevates the mandible. The masseter attaches to the zygomatic process and elevates the mandible. Here's the masseter. Its origin here is on the zygomatic process. It inserts in the mandible, it elevates the jaw, and we chew, and we get this kind of chewing action. The mandible is brought up. Notice how the mandible, the maxilla never moves. The mandible is brought up against the maxilla all the time because of these two muscles acting together. Okay. On top of our shoulder, behind the, the deltoid is trapezius, right along the top of the shoulder. And in the front of our of the thoracic cavity is the pectoralis major. If you have a major, you're going to have a minor, but we can't see the minor on here. There may be a thin line where the minor is located, but all we can see is the pectoralis major. Trapezius, large muscle on the upper back. It allows us to shrug our shoulders. It allows us to elevate our head. Notice how large this muscle is. It extends up to the base of the skull, right around the occipital region. But it also extends all the way down to the vertebrae in here. But when this muscle contracts, we can extend our head or we can shrug our shoulders. Like trapezius action, shrugging our shoulders, turning our head to the, rotating our head to the left or the right, moving it back and forth. Not like what the sternocleidomastoid allows us to rotate it to the left or right. Here we can move it backwards and forwards or tilt it side to side. That's what the trapezius allows us to do. Or we elevate the scapula over here. Our scapula is going up. We essentially shrug our shoulders. Pectoralis major. On the pectoral region of our body, we know where the pecs are. They are large muscles. We use the pecs if we are doing push-ups, if we're climbing, sometimes if we're throwing things. We put the very powerful muscles. They insert onto the humerus. Now, large muscle of our back is the latissimus dorsi. This is the muscle we use when chopping wood or driving nails. A good overhand swing, power stroke is going to be brought on by the latissimus dorsi. It's a large muscle covering most of the lower back. It allows us to, again, think of driving a nail with a hammer, or throwing a ball underhanded with a power stroke. This is the latissimus dorsi right there. Notice the power stroke behind that. If you've ever seen fast pitch softball, think of that. That's what you use in softball, when you watch a softball game. And the ball is pitched underhand. It's a just as powerful throw as an overhand throw. Okay. The rectus abdominis, the six-pack. The rectus abdominis is a large muscle in the abdomen. When we go to, we call it the six-pack because of the separate muscle segments in here. When we go to pick up something very heavy, we stabilize our abdomen with this muscle. We hold our breath when we do that because we can't allow our diaphragm to flex up and down if we're stabilizing the abdomen. So when we contract this muscle, it stabilizes the abdomen, but we're holding our breath. This is the muscle that is used when someone is straining to pick up something heavy, straining to empty their bowels, coughing violently, sneezing powerfully. This is when where an individual can cause damage, when they can have generate a hernia in here, right? What it does is it raises the pressure inside the abdomen. So it flexes the abdomen. So the external obliques are abdominal muscles. They compress the abdomen. We use these muscles too to pick up something heavy. You want to know where your external obliques are? Stand upright, stick your hands in your pocket and point your fingers towards the midline of your body. And your hands will be sitting right on top of your external obliques. And if you want to know where the internals are, they're directly underneath, but they're running in opposite directions. So they compress the abdomen. Here we see the serratus anterior, muscles along the side of the thoracic cavity. You also see the intercostal muscles between the ribs. Those are the external intercostals. Here again is the rectus abdominis and the external oblique. The internal obliques will run directly underneath that, but in the opposite direction for extra strength. We look at the inside of the abdominal cavity. We see the intercostals. These are the internal intercostals. You've got external and internal intercostals. You see the internal obliques here, but just as a line. You see the transverse abdominis, and you see the diaphragm. Now, the diaphragm is this structure right here. It's shaped sort of like a parachute. It is not this area in here. You really can't see much of it here at all. But so for testing purposes, the diaphragm is this little line up here, just to give you a heads up on that. So now, the external intercostals, the grain on the intercostal runs toward the sternum. So you can tell it's on the it sits on top of the internal intercostals. The grain on the internal intercostal, the line of the fibers runs away from the sternum. The external intercostals elevate the ribs. When they contract, the ribs rise. When the internal intercostals contract, the ribs are depressed. Now, when we take a breath, we elevate our ribs to increase the size of the thoracic cavity. At the same time, the diaphragm drops. When the diaphragm contracts, it drops. The diaphragm is located directly beneath our ribs. If you know where your xiphoid process is, you know where your diaphragm is. The edge of the diaphragm is there. It is shaped like a parachute. So this is what the true shape of the diaphragm looks like. And if you watch this, you can see what happens when we breathe. When the diaphragm contracts, it drops. The thoracic cavity increases in size. At the same time the diaphragm contracts, the intercostal muscles contract and the ribs rise, giving you the maximum size for the thoracic cavity. Notice how the ribs, when the ribs rise, the diaphragm goes down and the chest expands. So, okay, and that is everything on muscles. So, any questions on muscles? When we come back from break, we'll go over the muscles again before we have a test. I would anticipate the bone test opening up sometime during the week of spring break, and the week after spring break, and staying open for a week to give, so you'll have a little more time to get ready for it. So, any questions on anything? Okay, then I will see you all in lecture on Wednesday, and we'll continue on metabolism. So have a good rest of the day.